Um, Good morning, everyone, and we're very pleased to have with us Dr. Mani Baskaran. Mani is, as I often say in jest to myself, he's a long lost friend, and Mani grew up in Sankara Nethralaya and did very well, and then went on to join the Singapore National Eye Center. And he's had a great time over there, participating in epidemiological studies and also in especially primary angle closure glaucoma studies, which is of significant interest to our country. As you know, that Singapore is a kind of leader in angle closure studies and has given us a lot of knowledge. And Mani is a part of that big and prestigious group. And we're very happy to have you here with us, Mani. And I hope you will take us and give us a lot of knowledge about the implications of anterior segment imaging, in the diagnosis, treatment, and other important clinical findings in relation to primary angle closure glaucoma. And I'll hand the mic over to Rajiv. Rajiv, I'm sure all of you who are attending this session is a consultant and has done a lot of work himself in so many areas in retina and also in artificial intelligence. Welcome, Rajiv. And if you have a few more words to say about Mani, because both of you have been together at Sankara Nethralaya for such a long time, please do.
So welcome, Dr. Mani Baskaran, and actually welcome all of you. I hope this series of webinars on imaging has been useful to all of you. And today, last couple of weeks, we have been looking mainly at the retina related imaging. And today, Dr. Baskaran would be talking about anterior segment imaging, especially more so towards glaucoma. Actually, Dr. Mani and me grew together at Sankara Nethralaya. He was senior to me here, and really, the way he was a part of Chennai glaucoma study too, and he took this interest to Singapore. And just wanted to give one thing, that today, if you look at the leading researchers in India in ophthalmology, I rate him as one of the best researchers. His index is more than any ophthalmologist in India. It is 47. I don't see any ophthalmologist in our country who has touched that H index. It speaks high of the impact of the publications, of his publications which have been there. And I am sure his return back to India from Singapore will really boost research, not only in Sankara Nethralaya, but even the others who will see him, and that will be a great contribution to India now. Welcome, Dr. Mani, and he will speak about the imaging, anterior segment, newer aspects of imaging. Dr. Mani.
Thanks a lot, Rajiv and Dr. Vinay Nangia, for those nice words. I'm humbled by the experience, and thanks for this opportunity. Let's move to the presentation. I think the screen is being shared now. So let's.
Yes,
you can make it full screen.
Yeah, I'm just making it now. Okay. So imaging of the eye, anterior segment of iris and angle. So basically, I've just taken the thing angle closure glaucoma and made it as angle closure disease, because the angle closure glaucoma is such a smaller spectrum of the entire angle closure disease. 4% incident and prevalence compared to around 12% of angle closure suspects and angle closures and the secondary glaucoma. So there is some financial interest in some of the device patents and software patents that I'm going to talk about. Of course, nothing of a greater earning mode just now. I hope it's moving. Okay. All right. We'll start with the case study. This is a 55-year-old female who presented with pain and watering in both the eyes one day post cataract surgery IOL implantation. It was ECC IOL done for this patient, and subsequently the fellow eye had an uneventful ECC IOL implantation in 2005. These were the clinical features: hand movements close to face, grade 0 anterior chamber depth, and IOPs were high 48. Pupils were not dilating much, periphery can't be seen, there was some hyperemic disc. Now, the suspected bilateral aqueous misdirection, and we went ahead with treatment for the same. It was ineffective, including a YOG hyalotomy. So UBM evaluation was done. As you can see, there was choroidal effusion. So obviously the UBM is the one which can pick up past the iris lens diaphragm. And we suspected drug-induced choroidal effusion, and acetazolamide was withdrawn. And subsequent to which, 3 days later, cornea cleared, IOPs were normal, and the anterior chamber was formed. And a month later, the patient was normal with 6/6 vision. Sulfur drugs such as this acetazolamide and other such drugs can cause an idiosyncratic reaction and an uveal effusion, causing similar to the malignant glaucoma type, like anterior rotational ciliary body. And of course, relaxes the zonules, also causing myopic shift. This was published, and Arun was the person who had done this. So imaging has its importance in management of our patients, and with further technology, we are moving into the era of angle closure detection, automation, and everything. So we should be ready for such a thing. So this talk will have an overview of angle pathology, angle closure detection, and lens IOL related angle closure, ciliary body choroid involvement, how it is there in angle closure glaucoma, and a little bit on deep learning for detection and some high definition imaging for the future. So we all are familiar with this picture, gonioscopic image of an open angle and a narrow angle. And that's the UBM image of a closed angle here, a cross-sectional image which tells us the entire anatomy there involved. Of course, it is always difficult to do gonioscopy. Even it is a skill to be learned and to be followed. I'll be very precise in the beginning itself. There is nothing to replace gonioscopy in your clinical practice. As an ophthalmologist, you should be able to interpret gonioscopy. However, the imaging tools are useful in a large patient setting, or when we have problem using the gonioscopy in such a patient, or when we want to have more details for past the iris lens diaphragm. So we kind of devised something similar to gonioscopy called the GonioPEN. It is almost the pen size. It's similar to the red cam, the eye cam part, the anti-segment photography part, and we were able to image the angle with that very easily. Of course, the design and technology is different from the red cam, and you can see the images from the angle are clearly seen. This is an older photograph. Now the images are almost similar to the red cam, and we are in the way of getting past the prototype to productization. So we also had a higher resolution version of it. You can see the angle details here very clearly, and this, if it can be accomplished, can be very useful in documentation and follow-ups as well. And subsequently, of course, the interpretation is a bit of a problem. Of course, when it is seen by an ophthalmologist, it is easy to interpret, but when it is going to be seen by people who are paramedics who probably would use it, like optometrists or the technicians who are going to do it. So we wanted to have an automated solution so that all the open angles are taken off and the angle closures come to the ophthalmologist to confirm. So you can see that this particular software automatically detects the open or closed angle from a gonioscopic image. Surprisingly, this software works with any kind of gonioscopic image, and we hope to integrate it with this GonioPEN so that it will be useful as a opportunistic detection tool in the clinics, because we can't do gonioscopy in every patient, and that's a practical thing that we are so only the angle closures we go on to confirm. So as you can see, this is a closed angle that is getting done in real time. So this is the time taken for detecting it. You can put it in a printout, give it to the patient, useful for follow-up as well. And that's the first ever picture taken by Pablin using the UBM. You can see the entire anatomy of the angle ciliary body and the cross-sectional longitudinal view of the ciliary body as well. So we initially did a comparison between UBM and the gonioscopy for comparison, and this was published in way back in 2004 in Japanese Journal of Ophthalmology. And you can see that the cutoff value of 20 degrees seemed to coincide very well with gonioscopy as well. Of course, it has its problems. It's a contact procedure and it is a bit of tedious, needs a lot of skill. However, it defined the way in which we are looking at the angles. There are oppositional angles, extreme oppositional angles. There are pseudoplateau iris where you don't have the typical rotational ciliary body anteriorly. and of course some of the borderline angles which we have to follow up. And we also found some iris, the insertion variations. Professor Ming Wang He from China was trying to elucidate some results pertaining to the course of the disease using these insertions. You can see that posterior insertion to the ciliary body here, and then mid insertion, and then at the tip, and they call it with different names, S shape, U shape, etc. So these are some of the things, interesting things, which need further research into what is the course of these angle closure patients. And then came the anterior segment OCT. You can't see the ciliary body and pass the iris lens diaphragm, but you can have a very nice image of the angle, and it can be used as a initial opportunistic screening for patients who come to your clinic. And or when you have a problem, deciding from gonioscopy, you can do it for confirmation. And that's how we can use the anterior segment OCT for angle closure. And you can see that there is a bit of a high definition, high echoic reflective trabecular meshwork is seen, and if you can detect the scleral spur, you will be able to tell whether it is closed angle or open angle qualitatively. However, there were problems in detecting the scleral spur. Only 72% of the patients were able to detect angle closure, and still it is getting improved with newer versions as well. However, it is being extensively used in many of the other places where, I don't know, for whatever reason, gonioscopy is a problem for doing, which I would not encourage actually. But in a large number of patients who are coming to the clinic where the prevalence of angle closure is high, like in the Chinese population or in the Asian population, this is probably a good tool to use if you have one. And it also had this quantitative measurements which were useful in research. It has been used in multiple RCTs and cross-sectional studies. And it also has a problem because any kind of opposition to the trabecular meshwork is seen to be a closed angle in the initial studies, and that over-diagnosed closed angles compared to gonioscopy. And sometimes when it is closed on gonioscopy, and anterior segment OCT suggested an open angle because there is because of the resolution itself. We had a study following up these patients for 4 years and found that those patients who were closed on gonioscopy at baseline, at the end of 4 years, they get to close with the anterior segment OCT. So it is worthwhile that without doing a laser treatment, these patients can be followed up and can be treated subsequently. And that's what the recent RCTs from both China and Singapore, which I was involved, tells us that asymptomatic narrow angles we can follow up without the laser PI. However, we have to be cautious in certain age groups and complete closed angles. Because of this discrepancy between gonioscopy and ASOCT, we were trying to do this classification algorithms using the various parameters, and we were successful in getting a very good performance with gonioscopic angle closures. And then came the 360-degree imaging, and we hope that it can be similar to the gonioscopy, and that is the Cassia SSOCT. And there was this semi-automated index which is given by the manufacturer there, and it will give you a nice picture of open or closed angle using this device. 28 scans are taken, and then you can see whether it is closed or not in most of the areas. And subsequently, this index can give you how much of iridotrabecular contact is there. But it is a tedious thing to do. You cannot practically do it in the clinic. And thus, we subsequently developed an automated method of detecting it. However, it's a bit much. It's still, we have published a couple of papers, but then the performance is not that similar to gonioscopy. That simply tells us that probably we are either underdiagnosing with gonioscopy or this device is overdiagnosing. The answer is yet to be found out. And of course, there is this high definition angle imaging. We'll talk more about it later on. We can see the scleral spur and the collector channels, etc. And this probably, they're thinking that will be useful in this MIGS kind of devices. And when I was in Singapore, they started doing this MIGS even in angle closure eyes. So this high definition imaging may be relevant to angle closure eyes as well. So coming to some of the clinical aspects and the mechanisms involved, imaging is very useful in mechanism of deciding what mechanism of angle closure the patient has. And the usual thing is the pupillary block mechanism, and with the PI it gets opened up. But the role of the lens seems to be more in the Asian population. So you can see sometimes an increased size of the lens, increased anterior position of the lens, or a normal size in a small eye like the nanophthalmus, or phacomorphic glaucomas or anti-subluxation of the lens. You'll be surprised that in acute angle closure patients, if you try to do imaging routinely, you will see varying lenses which will have implications in the management of the patient. This is one of the parameters that is done in anterior segment OCT called lens vault. It is measured anterior to the scleros per line to that central position of the lens. You can see it is the lens vault, and if you see steeper the lens vault, you will end up having angle closure. So if you have a steeper lens vault and you have an open angle, those patients need to be watched, obviously. Of course, in a gonioscopy, you will see a slightly shallower anterior chamber. There are exceptions to these rules. Plateau-iris and myopic angle closures may be different. And with the CASIA 2, the entire lens can be imaged. Of course, this was being used in various other procedures, but angle closure patients, the lens thickness can be measured using this as well. And you can see that in some these acute angle closures, you end up with either a large lens or it has the cataract surgery before and after can be seen to open up the angle nicely. And this is some of the things which prompted the Eagle study to take up this trial for cataract extraction. Of course, it has its controversies, that is for another seminar, but implication of cataract surgery or lens extraction and angle closure is something which we cannot deny. And once we do the LPI, we open up the angle, but with cataract operation, it opens up much more. One cannot be complacent. One of the recent experiences I had is a case example, actually, even though we know about it. One of my professors from medical college, he had a cataract surgery done in both the eyes in 2007 by Dr. Vijay. And that time he had a primary angle closure. And subsequent to which the IOP became normal, angles opened up. He didn't turn up for follow-up after 1 year because everything was normal, in spite of my warnings. And ultimately, last week he came back and he had a superior arcuate effect. So one cannot be complacent that angle closure is only mechanical. It can have a mixed glaucoma, and even after cataract operation, we need to follow up these patients. Coming back to the lens-induced acute angle closures, you can see if you do routine imaging using UBM, you can either have a phacomorphic lens there, or a traumatic subluxation, or a loose lens syndrome. As you can see that the rounded edge of the lens with the loose zonules can be there. So these things have implications in management if you're especially going for a trabeculectomy or a lens extraction in these patients if LPI is not working. And of course, one cannot forget about the microspherophakic lens and the clinical tests that can be done to make sure you're not getting into trouble if you're taking up for cataract surgery. And of course, phakic IOL related and vitreous hemorrhage related angle closures are to be watched for. And this is a patient with a star ICL put up in the patient and had a secondary angle closure, probably a blocked peripheral iridotomy. And you can see that this imaging will help us decide about the management itself, position of the lens, etc. Because once you go inside, you should not have surprises. Of course, when talking about pupillary block, this reverse pupillary block and the PI mechanisms are also something which we can remember. And one of the RCTs which we did on angle closure patients with phaco GSL utilized this imaging and found that the iridotrabecular contact and the PAS areas reduced much more in the phaco GSL group, and those which had less PAS had better outcomes. So these are some of the research tools which can be used to confirm our findings. And coming to the plateau-iris mechanism, this is a classical plateau-iris. You can see that peripheral bump, anterior rotational ciliary body, and central deep anterior chamber, which will not respond much to the PI. Of course, some of them will have mixed mechanism, pupillary block as well as plateau-iris. It will open up to some extent, but may not be opening up fully, and UBM will confirm it. And this is where there is a difference between ASOCT and UBM. you can find out what is behind the iris. It can be a plateau iris classically or a pseudo plateau iris with cysts. But the contour of the ASOCT will give you some indication that it can be, a problem in the back of the eye. And secondary angle closures. And these cysts can be of different configurations. Multiple ciliary body cysts are common, and one need to be careful about treating them, because these are very common and they may fluctuate with hormonal changes as well. Usually nothing need to be done for these multiple ciliary body cysts, but one should be careful about a tumor in the back of the eye. So if you suspect, get an UBM done and image it, especially in an older age group patients. And of course, there are RCTs that have been done, and imaging was used to find out the response of the iridoplasty. There are variable results with plateau iris and angle closures for iridoplasty, but in some of the Southeast Asian countries, they use iridoplasty for acute angle closures. Because mannitol takes time, and these patients are in pain, and so they do iridoplasty and then subsequently do that decreases the intraocular pressure, and subsequently they do a PI. So that is one of the implications that came out of such imaging work that has been done. One of the other things is the cilioporoidal effusion in acute primary angle closures. For some reason, this is something which is understudied previously. Recent years, this is coming up in the mechanism as well, and this has given some insight into some of these pathologies in acute angle closures. There's excellent work done by Hiroshi Sakai, suggests that acute angle closures are the maximum incidence of effusion, followed by the fellow eyes of angle closures, and primary angle closures also have effusion. Surprisingly, some of the open angle glaucomas also have choroidal effusion. So there is something to do with effusion and intraocular pressure and angle closure more, and we need to dwell more into it and try to see how it works in the management. And we can also see this effusion in malignant glaucomas. And surprisingly, some time back, we had a thought process that with treatment, with medical treatment, if the effusion goes away, that these patients may not recur that much. And if there is an effusion, these patients may go in for surgery. So that is something which I'm not sure it is empirical, whether everybody follows it, but that's something which is food for thought and probably need more research into. Okay, that's about the clinical aspects of angle closure. So quick word about deep learning technology and angle closure imaging detection. So we try to work with this neural networking, and we use that to get some of these automated tools with various OCTs. And you can see that it automatically detects angle closure in in no time. Also, it gives all these parameters. So this works with any kind of OCT, and this can be a very useful tool to detect patients with angle closures in a clinic which is having a higher incidence of or prevalence of angle closure. And the performance of this device is quite good. It's almost 0.95, which is good for such detection purposes. Coming to high resolution imaging, this will be the last part of my talk. So with advancing high resolution technologies and computer speed, we are having digital enhancements of the images, ultra high resolution OCTs, and OCT angiography, which can be used for both open and angle closures. And we can see this volumetric scans, as you can see with the Cassia, giving some excellent details for the lens and the iris and the angle. And also people are trying to get the cross-sectional view of the Schlemm's canal as well. And this is being more and more getting popular with the various mixed devices. And ultra high resolution OCT, even though it doesn't have the penetration depth, it's being used more in the cornea, but we can actually image the Schlemm's canal much more clearly. And some of the software compensation methods give you enhancement of these scans as well. And some of this in vivo catheter probe OCT imaging also coming up, and these can be utilized in some of the newer mixed devices for examination of the angle. And in when I was in Singapore, they have started doing mixed devices in angle closures as well, and it started working in them as well. So it is relevant to angle closure as well. And some of this OCT angiography, we have started looking at the blood vasculature, how the healing happens, more in the research purposes, but may become a part of clinical practice in future if it is made easy, and algorithms are there to define which kind of bloods will go in for failure, and we may be using it for management purposes as well. I think there is a lot more to come in this future, and we will look forward to more technology helping us, assisting us, and probably giving us more work actually. So we should keep abreast with this, and I hope such seminars will be of very good help to keep us, abreast with the future technologies. With that, I would like to acknowledge all these people from Singapore, Chennai, of course, Dr. Vijaya, my mentor, and Dr. Tinong, my research mentor, and all the other people, technology people who worked with me to get some of these software applications and devices. Thank you very much, and I would like to take questions. Dr. Vinay Nangia and Prabhat.
Yeah, maybe I can start while we wait for the audience to ask Mani, and so I wanted to your webcam.
You are muted, sir.
Am I muted?
Now we are.
Now fine.
Sorry? Okay, but Mani, we can't see you actually. You need to come on screen. So can you switch on your webcam?
Okay, I think there is something.
You can just unshare the slides.
Okay, so you mentioned you showed us the anterior segment scans, and and you also mentioned that you're creating algorithms, putting all the measurements of that you get on the anterior segment OCTs together to be able to better identify. And I just wanted to ask you, is lens thickness considered to be important in relation to lens walt? Lens thickness is something that's very easily available. You don't need technology to identify the scleral spur, and lens walt is a little bit more difficult unless you have, is that something that you would consider as being an important risk factor in our class of patients actually?
Okay, generally lens thickness is something which is useful only when you have an angle closure. So that's what we found. Lens thickness seems to be having a very weak correlation with any kind of risk with angle closure or acute angle closures. Lens wall seems to correlate more. So that is what we have found in various work that we have done. Even relative lens position and all those things are not that much correlating. I won't say that they correlate more with angle closure than open angle glaucomas. So if you don't have a lens vault measurement that is possible, lens thickness can still be useful. But the problem is, when you are trying to do a screening or an opportunistic detection, their performance is very weak. And so I'm not sure standalone lens thickness may not be useful. Maybe anterior chamber depth with peripheral anterior chamber depth measurement, if it is possible, or a combination of lens thickness and relative lens position. These things have shown to show a little bit more, but nothing beyond 80.8 AUC. So that is why we need to be careful using them, because you will end up with a lot of false negatives.
Yes. Yeah. So in a typical clinic where we don't have the anterior segment OCT, if you're suspecting based on your slit lamp examination or gonioscopy, if you're suspecting that this person is a patient that might go in for primary angle closure disease and is showing and is a primary angle closure suspect, what sort of investigations, biometric parameters would you recommend be done as a routine?
I think if you do not have an ASOCT, and if you only have a biometric, the routine biometry, simple anterior chamber depth would be sufficient, along with your Van Herre grading would be a better choice, because that seems to have Ronnie has done that work, and it has shown Dr. Ronnie George. He has done this work, and a combination of anterior chamber depth with the peripheral Van Herre grading would be a simple way of enhancing the risk profiling. and he got something like 0.9 in our population, so it may be more relevant to us.
All right.
So I think I cannot think about anything else which can be from a routine clinical practice can be used.
Okay, thank you. And I'll come back to you.
There is a question. Yeah, there is a question by Dr. Alka Pandey.
Yes.
In case 1, the acetazolamide was started only when the patient came with high IOP. So there was some other mechanism before the acetazolamide induced aqueous misdirection happened.
We couldn't find anything else. That is the problem. So in this case, we have a documented sulfonamide associated idiosyncratic reaction, which is available in the, and in fact, there are some other literature also on acetazolamide induced choroidal effusion. That's why we suspected it. And as you can see that,
So
it was
acetazolamide for eye problem, was it used for high pressure or it was used for some other condition?
No, it was used as, I think for the ECC IOL for that particular patient, they used it as a post-operative prophylactic as well as, yeah, that's right. So probably, the patient had a bit of a narrow angle before and they didn't want to, probably the patient did not have a PI before the surgery. So they took, they've given acetazolamide as a prophylactic. So there is a documented evidence on this idiosyncratic reaction. So that is why it was reported. So, as you can see, it is an anecdotal case report. So we cannot be 100% sure. Yes, I appreciate that question, but there is some evidence of choroidal effusion induced by acetazolamide paradoxically. When you use it for a higher intraocular pressure, it can induce. So you've got to be careful. After use of acetazolamide, if you see a further shallowing of the anterior chamber, try to look for choroidal effusion. That's all. And you may have to remove the acetazolamide.
There's a question by Dr. Ramaswamy.
Yep. Dr. Krishnadas.
Can some quantitative quantitative parameters on ASOCT prognosticate any PACS will require prophylactic LPI?
Well, that's a good question. One of the things is the lens vault. That's why I highlighted it. If you have a steeper lens vault, one need to be a bit careful about that patient. You may want to treat the patient with LPI, but I think, one need to take these quantitative parameters and ASOCT, all these things in the context of case detection. Once it comes to the ophthalmologist, we need to rely more on the clinical parameters and the other risk factors that we see. Quantitative parameters as such can only give us an indication that this patient has an angle closure or not. And subsequent risk profiling, I think we have to do. And whatever other risk factors that we are seeing, like, patients more than 60 years of age, and, patients with diabetes, of course, and patients with 4-quadrant closure, grade 0. These are the patients who are at risk of progression. These are the results of one of the RCTs that we have done in Singapore. It's the analyst trial, and the RCT is getting almost finalized and getting reviewed. So hopefully it will get published. So we need to look for other risk factors for treating the PACS patients. And of course, our context, in our country, we have this problem of follow-up. So if a patient is not going to come for follow-up to you regularly from a remote place, probably you may need to do the PI. So there are clear-cut guidelines for this in the WGC consensus also. So I think we can follow them. And as far as the quantitative parameters, please look for this lens vault. If you see that, that if you have a very steeper lens vault, then you may want to treat the patient with laser, and especially with all quadrants closure.
So I'll just lead you on to another related question, that is there a significant correlation between the lens vault and the lens thickness?
Yes, of course. Lens vault and lens thickness have significant correlation, but then you would expect it to be 0.9, but it is not. So in most of the studies, it is somewhere between I would say even 0.4 to 0.6, 0.7. That's what we found. But that is mostly in Chinese eyes. So I think we need to have more data from our population. Dr. Nangia, I think you have enough images. You should try and do some of this.
We'll get there.
Yeah.
All right, that's tremendous.
So the lens thickness and lens wall doesn't always correlate, and that's the reason why a lens thickness performs poorly when it comes to standalone parameter for angle closure detection.
Okay. Do we have any more questions from the audience?
Just one question I wanted to check, see, because diabetic retinopathy screening, now there is use of non-mydriatic cameras throughout the country. And the problem of non-mydriatic camera is that 30% of the images are non-gradable. And it's always better if the same camera we take with a dilatation, the image quality improves, but there is always this fear of angle closure. And people do a Von Herrick. So is there anything you are aware about automated Von Herrick?
That's a good question. Tried to do it actually. There are still there's one particular researcher who is interested to do it, and there is one, I think, from Hong Kong also. They are trying to do it, but the problem with that automated Von Herrick is again the performance, right? So as a standalone parameter, it may not have the sensitivity specificity for detecting all the patients. So again, I would say refer to Dr. Ronnie's thing. If you can see a combination of anterior chamber depth and peripheral anterior chamber depth would be good. There was a device called SPAC. I think we published it way back in 2009. This was a Japanese person, Kenji Kashiwagi, who made this device. So it is an optical device which takes the peripheral anterior chamber depth. So from it takes both the central anterior chamber depth as well as the peripheral anterior chamber depth. But the only problem was it uses visible light, and it actually opens up the angle. So if you had used an infrared light and then used this device, then it would have been a very good device actually to screen before your diabetic retinopathy, for dilatation. But again, I would say that post dilation acute angle closure incidence is very low. But in a country with our population, if you end up dilating every patient, you will have probably large number of acute angle closures. So numbers, I'm talking about numbers. Percentage wise, it is probably 0.04% or something, the number of acute angle closure that happen after dilation, but the numbers will be huge. So you want to be careful about dilating the patients without checking for narrow angles. But definitely the incidence of acute angle closure is very less and it is treatable. So, dilating patients and doing photography, it is again a debatable thing. So if you're
see, because
careful,
100 is too much actually. So,
sorry.
No, 0.04% is actually a high as far as Indian, when you do a screening, mass screening, it really is a bigger number. And many times the screening today is done by technicians and there is no doctor there. That is the reason why government has not allowed any dilatation in the periphery without presence of a doctor. In the camps, they don't allow to dilate. So I think that is one of the reason, but I agree. And ideally, if something, though for a Von Herrick, you need a slit. If ideally with a diffuse illumination of a fundus camera, if we visualize the anterior segment and there is some algorithm which gives us some idea, I'm not sure that it can give any idea or not, but with today deep learning algorithms, if we label these anterior segment images with the gonioscopic findings and try.
I know that there are a few people working on it, so definitely you will get some kind of a tool coming up, and they will integrate it with this diabetic retinopathy screening fundus cameras.
Can I take a completely a different view of I just want to tell you that I suspect, and based on what we've seen in our clinic and with the huge amount of dilatations that we've done, even though we use slit lamps and indirect ophthalmoscopes to examine patients both inside the clinic as well as in our outreach activities, we don't have yet in so many years even one single reported case of angle closure, acute angle closure following dilatation. Actually, not one single case in so many, in more than 2 decades actually. So there is this feeling that
so you do
precipitation
some
of
lab examination before dilation, right? Van Rix,
yes, Yes, we do Van Herrick's. It's a slit lamp examination. We get slit lamps in all our outreach clinics. But I'm just trying to tell you that it's something that probably, you know, the iris in our country doesn't respond to dilatation in the way that the iris probably does in East Asia or even in Caucasian eyes, actually. And therefore, while we are increasingly predisposed to chronic angle closure, but we appear to be much less, if at all, predisposed to having acute angle closure precipitation. So I think for Rajiv, of course, studies should be there to document this. But for Rajiv, actually, it's a huge green signal that, you know, that when you need to, and of course, that, you know, using a torch light from the side, that's a very old test, and there is some literature on that also. You know, that is something that technicians can be trained to do to a certain level, and that may actually help. And if you need it, then you could put a torch light from the side, and you could use the fundus camera to document the lightning of the lighting in the anterior chamber, and that would be a evidence that this patient, you know, was reasonably safe according to the torchlight test in determining whether there is a high possibility of precipitating angle closure. But I think it's a very interesting aspect, actually. I wanted to take you, Mani, to another very interesting parameter that you brought up, and that was peripheral choroidal effusion. You know, the cilio-choroidal fluid that you showed. You know, you would remember there was a huge debate about the importance of choroidal thickening in precipitating angle closure. And you know what role the choroid had, while that was in general the choroid as you know getting thickened and congested, and therefore you know pushing the vitreous forward and the lens forward, but just now you know locating it just to the periphery with the cilio-choroidal effusion, I think that is a new sort of finding. And you know, and especially when you say that this is something that you've seen also in primary open angle glaucoma. That so you're saying that high pressure primary open.
You're not audible now, just now.
Yeah. Some network issue, it seems.
Okay.
Angle
Maybe
glaucomas could show cilio-choroidal effusion, and you're leaving out the normal pressure glaucomas.
Well, I think it was Hiroshi Sakai's work, and he had the primary open angle glaucomas as the controls. And I know that with this talk, majority of the patients were actually, you know, the Hiroshi Sakai, he comes from Japan. So many of them are actually normal tension glaucomas as well. So they are not just high pressure glaucomas, but I would rather say that, you know, it is an intraocular pressure imbalance kind of thing that happens in some of these patients, you know. So I wouldn't say that all of them are high pressure glaucomas. So there are sizable amount of normal tension glaucomas also in that controls. But the choroidal effusion percentage, if you saw, it was only 1.3%. And we do see choroidal effusion in some of the diabetic patients also. If you know, when we try to do some some other screening for choroidal effusions, we saw many of the diabetic patients having effusion. And if you have noticed, you know, post angle closure patients with choroidal detachment, diabetic patients have take a longer time to resolve. So there's probably that, you know, some of the diabetic patients exhibited choroidal effusion. I'm not sure if Hiroshi Sakai controlled for this diabetic patients. So I'm not sure the percentage of effusions in primary open angle glaucoma is a true indication of glaucoma related effusion.
All right, I think that's tremendous. Rajiv, is there something that something else that you'd like to ask, or anyone else on the? I don't know.
What
There are more.
like peripheral choroidal. Just one
Right.
question. Peripheral choroidal changes which you are telling, I'm sure this will also reflect on the posterior pole, or now with swept source OCT looking at 12 millimeter scan. can we look
Yes.
at those peripheral choroidal changes in the posterior retina with a swept source OCT? Has anybody tried correlating these two?
I would probably think that it will be very difficult to detect any effusion, because we have looked into that part as well at that time, but we used that enhanced depth OCT kind of thing that time, but not this web source OCT.
Because swept source gives a very good quantitative measure across 12 millimeter, of nearly about 30 to 35 areas. You can map the choroidal thickness, and you can see the both satellar layer and the halar layers. So
Yeah.
all these gets communicated in the periphery. So definitely there will be some telltale signs of what is happening in the peripheral retina in the posterior pole too.
I think that if you use the anterior segment swept source anterior segment OCT, then you could probably end up screening the anterior part of the retina and choroid. Actually, that might probably help you to see that. Actually, there's a question that from Krishna Das that we missed out. I didn't scroll down, and he was asking whether there's any cutoff value, LV value, lens volt value, that would necessitate prophylactic LPI.
Okay. No, I don't think so, because we actually looked into all the 6 parameters and prepared an algorithm for screening, but we haven't specifically looked into that cutoff, because if you see the analyst study and the ZAP study, these are the only 2 things which looked at progression so far, and the number of patients who progressed are quite less. So if you take the ZAP study, they had only I think 40 plus patients who progressed among 880 patients, and we had almost 480 patients enrolled in the study for analysts, and we had I think something like 70 patients progressing. So these are 2 small numbers, and it's difficult to really find a cutoff value from this. So probably you need to have a large study which is following up these patients to find it out. But I think at the end of the day, whether it is a good exercise to do it or not is a question. Finding one particular parameter for deciding a cutoff for LPI, so difficult.
Rajiv, can you take up the next question?
There is a question by Dr. Hari Shankar Nag. A patient with PACS with cataract, should PI be done before cataract surgery, or can we do cataract surgery?
I think we can go ahead with cataract surgery, but remember to do a PI in the other eye if you are delaying surgery for the other eye. So PACS, if the patient has an indication for that, right? PACS patients can be followed up without PI also with the current context of asymptomatic PACS patients. But if they have other risk factors, consider doing a PI in the other eye. But if patient's cataract is significant, I think we should go ahead with doing the cataract surgery. Dr. Vinay Nangia, how is your practice in this?
I mean, we've actually, been extremely conservative for a long time with doing laser PI, because we've always considered that laser PI has a cost actually to the trabecular meshwork that we never took into account with the degree of pigment dispersion that goes into the trabecular meshwork. So we've always been extremely conservative with doing PI, and the only definitive this thing that we have is either the patient has PAC, or the other eye has got PACG, or the other eye has got PAC. Only then you would do the other eye, laser peripheral iridotomy. But in asymptomatic patients without any family history and without any evidence of PAC or PACG, we have generally been extremely conservative in doing laser PI. Actually,
Agree. That is the correct context.
Dr. Das has a question. How can we quantify the space between trabecular meshwork and iris surface?
Quantify. Actually, if you see the space? Yeah, so if you see the the 6 parameters that we used in the classification algorithm, one is the anterior chamber area, another is the anterior chamber width. Of course, if you want to measure the angle, there are tools available as well, trabecular meshwork angle. Then there is the angle opening distance, which is basically a line drawn from the trabecular meshwork to the iris surface perpendicular. So, and then of course trabecular iris surface area. So these are all various parameters that are used to quantify. But the simplest thing would be to just measure the angle in degrees. So that will give us a direct indication, which will correlate with gonioscopy as well. So if you have an angle which is less than 20 degrees, then that can be considered as narrow angles. But it all takes a tedious time consuming effort. So mostly we use ASOCT or UBM for qualitative analysis. Just look at the UBM and then make an empirical decision. That's it. As of now, that's what we are doing. But I think with more automated tools coming in, we should be having measurements which will give us an indication whether it is open or closed.
Thank you. Do we have any more questions? Okay, we don't seem to have any more questions. Is there anything else, Rajiv, Prabhat? Is there anything else that comes to your mind?
Just one thought. Anybody has tried looking at OCT elastography? Like people are now looking at because for anterior segment, especially for glaucoma, it would be very easy because you can deform very easily the globe and try to look for changes which are happening. Is there any role of looking at the the rigidity or the elasticity of a tissue?
Problem is OCT elastography. I think there are only one or two devices that are available for research purposes. And if you know Dr. Michael Gerard from Singapore, that biomechanics engineer, he has been devising one OCT elastography himself. So it's a nascent technology, and yes, we would like to do and check the biomechanics, but it's very difficult to really get a measurement which is meaningful, because I was trying to do this kind of biomechanics of the trabecular meshwork, iris, all those things for angle closure patients. The resolution is a problem. So your OCT should have enough resolution, pixel sizes, so that this elastography thing can give you a proper quantified measurements. So that is the problem.
Sure.
So we need to have a better measurements, a better resolution, ultra high resolution OCTs, and then this elastography may work much better as well, which will give us some meaningful information. For cornea, it works perfectly. Yeah.
Yes.
In fact, they have started coming up with some of this biomechanics thing, and they have started experimenting in, working in patients as well. Only thing is, it all takes time. For one patient, it takes half a day for processing. So you can only get the result the next day for the patient. So we need computer speeds also to increase.
Thanks.
Thank you. That's great. So thank you very much, Rajiv, who's been a colleague on this venture, and thank you very much, Dr. Mani Bhaskaran, for being with us today. And it's great that you're here, and that everyone can connect with you, and I hope that the study of angle closure will grow in our country, something that's needed. Thank you very much for all the information that you've given to all the audience, and we hope that this video will continue to be watched also in time, as it will be made available to many people. And thank you, Prabhat, for having done all the background organization. Thank you very much, all of you.
Thank you, Rajiv, Prabhat, and Dr. Vinay. Hope all of you keep safe, and we can meet in person in future.
Soon, sir. Hopefully soon.
Bye-bye.
Thank you very much. Okay,
Bye-bye. Have a nice day.
Bye, sir. Bye.